for joining us this afternoon. If you wouldn't mind keeping yourself on mute, and then what we'll do is at the end of Morgan's presentation, I'll look for questions in the chat, or if you want to raise your hand, I can call on you. I don't think we have such a large group that that'll be difficult to manage. So we're fortunate today to have our REACH seminar speaker, Dr. Morgan Giers, who's assistant professor in bioengineering at Oregon State University. I've gotten to know Morgan through interactions on the spine section of the Orthopedic Research Society. And I asked her to join us today because you'll see that Morgan's work really overlaps significantly with the goals of BACPAC, in particular some of the imaging work that we're doing here at UCSF, part of UCSF REACH. So generally, her research focuses on technologies for predicting treatment outcomes for the intervertebral disc and treatments, either regenerative or surgical, using MRI, image processing, mathematical modeling, looking at transport phenomena, also trying to identify potential molecular or biomechanical targets for disc regeneration. Morgan is also co-chair of an upcoming symposia on the role of artificial intelligence in spine care that's going to be held at the International Society for Study of the Lumbar Spine meeting in Boston in May. So those of you who might be interested in seeing that, please take a look at that website for further information. So thank you, Morgan, for joining us today and talking to us about predictive modeling and intelligence-based spine care, One Lab's experience with phenotyping, machine learning, mathematical modeling, and imaging. You can take it away.
Thank you, Jeff, and thank you for that introduction. I'm honored to be speaking with you all today. I really commend you on BACPAC's incredible mission, and hoping to share some of my experience in the same areas. Like Jeff mentioned, I'm co-chairing a session at ISLS. So if you are interested in today's discussion, we will continue it there in Boston. I'd like to disclose that I'm the co-founder and CTO for Spine by Design, a company with minimal money and no employees or products yet, but hopefully you'll be hearing good things from us soon. So first, I'd like to take a look at this figure. This is a figure that one of my students, Philip Hernandez, made by compiling results from journal articles with follow-ups of 5 to 10 years. He traces the pathways that each patient, each percent of patients undergoing a specific procedure take to either satisfactory results or conservative treatment management. In this case, we can consider treatment management something of a failed surgery group, as these patients' symptoms never resolved. We can see a large portion of fusion patients breaking off and ending up in the failed surgery group. We can see a moderate portion of discectomy patients falling away as well, with a good portion of those getting secondary and tertiary surgeries before landing in that failed surgery group. I see predictive modeling as a way to identify these patients who are falling into this failed surgery group and try to navigate a path that will accelerate a patient's treatment to its most satisfactory endpoint by avoiding complications, avoiding failed surgeries, and changing treatment approaches to mediate risk. Now, of course, there are a lot of conservative treatments that I am neglecting here, but I know all of you are working on those. So for instance, these are all the factors with evidence for or against different surgical failure for different types of surgery. So green means it is associated with surgical failure. Yellow means that there's evidence to both support and refute an association with surgical failure. And red means it has been shown not to be associated with surgical failure. So if we start to make our way across the board utilizing big data, we can start to identify these relationships more precisely and predict specific complications and negative outcomes. My group has focused in on microdiscectomies, and I'd like to share our journey on how we can predict reherniation risk following microdiscectomies. And really the overall goal is that there are many spine surgeries in the US every year, about 1.2 million. And a lot of those fail to resolve the patient's pain. So what we're trying to do is minimize these frequent flyers. So for instance, for reherniations, they tend to happen within 3 months of the first surgery, meaning that they count as surgical readmittance and hospitals have to foot the bill. And of course, you know, having a reherniation several months after having an initial surgery is less than desirable for the patient. So patients will go back in for a revision surgery while still recovering from their first surgery. And this leads them down a pathway towards failed back surgery syndrome, more and more surgeries, and no relief. We feel that predicting reherniation risk is really important because there are alternative options for patients who would be candidates for microdiscectomies. They could continue with surgery. They could return to conservative management. They could, we could add a closure device or do a fusion instead. Or just, you know, tell the patient that they're at high risk and we need to work on minimizing that risk with, you know, a lighter sort of post-surgical regimen. So as a postdoc, I worked with Yevgeny Belik and a team of physicians looking at a variety of factors from 50 cases of reherniation and subsampled from over 1,300 cases of non-reherniated patients to obtain an age and gender matched cohort of 300 non-reherniated patients. Our initial process was to look at statistical significance for each of these pre-surgical metrics as independent risk factors. So you can see we considered quite a few metrics. We considered Fuhrman grade, modic changes, sagittal range of motion, DHI, lumbar lordosis, herniation type, and subchondral sclerosis scores, and degeneration of joint cartilage. We then ran a nonlinear multivariate logistic regression model on the significant factors or significant independent predictors. And those were the disc height index, BMI, sagittal range of motion, lumbar lordosis angle, Fuhrman grade, herniation type, and smoking. In this case, we ended up with 97% accurate prediction rate for our training cohort, which we were really happy with. And in fact, at that institute, we did a second round prospectively and got the reherniation rate down from 4% to 1% in that population. Unfortunately, when we tried this across several different institutes, we found our results were not quite as good. We still correctly classified no reherniation pretty well, but we weren't really accurately classifying who was going to have reherniations. And the major reason for this was a lack of consistency in the way a lot of these spine metrics were being calculated. So for instance, if we look at disc height index between our 4 different institutes, we see that the disc height for patients at St. George were about 40% higher than those patients at Emory. We don't believe that this is true. It's likely a result of us taking manual disc height index measurements. So when one person was taking all of the measurements, we did really well in this Novosibirsk cohort. But when we had different people at these different institutes doing DHI and sagittal range of motion, everything kind of falls apart. We see consistency in our more objective sort of metrics like BMI. We didn't see any change there across the institutes. So we're pretty confident that it has to do with the way we're taking these measurements. So that leads us, of course, in the direction of creating machine learning software for spinal image processing, specifically trying to develop neural networks for segmentation of the disc. We're still currently in our segmentation process, but I'll show you also several interesting calculations after the segmentation step that we think are very helpful. So we're currently in our segmentation process for our training data set using semi-automated segmentation methods. So we're using mimics in order to try to define where the disc regions are. So the data that you'll see coming up was all based off of manual segmentation using the semi-automated process. So one thing that we have looked at is the disc height index measurement. So for this, typically a person will draw an X shape on this spine at each vertebral level. And then they'll kind of connect the dots in order to find a vertebral height and a disc height. Now, obviously, these are not straight structures, right? The end plates are wavy, and when we consider degenerated end plates, they are even more, they have a lot of defects. So that might not be a great way to calculate disc height index in a tolerable fashion. So tolerant to minor changes in the way somebody places these lines. So what we've been doing is taking segmented discs. We can determine the center of mass for the disc. So this is the imaging center of mass, where each pixel is given the same weight. So if we can picture this theoretically, this would be if we took this object, let's say we 3D printed it with plastic, and then we tried to balance it on our finger. The center of mass would be where it balances in the long direction and where it balances in the short direction. So then we end up with the center of mass and orientation vectors for the long and the short axis. We're able to rotate the disc to be normal to the reading frame, and then create a bounding box. For this, we only utilize the width of the bounding box because the width of the disc ends up being pretty consistent, whereas the height, again, is more subjective to end plate defects. So after we do this, we calculate the total area for the intervertebral disc, and we divide the area by the width in order to obtain an approximate height. We repeat this process for the disc above, and then use our approximated heights to calculate where the end plates would be and approximate a vertebral body height. So when we do this, we compared the standard manual measurements utilizing end plates with our semi-automated segmentation method utilizing our center of mass and orientation vectors. And what we see is that you can tell kind of here from the different observers and the spread for each of these samples that they become a lot closer here in our semi-automated section. When we look at the disc height index for a single observer, so person A and person B in pairwise, we can see that they actually did pretty well. Their inter-class correlation coefficient was 0.88, meaning they had good agreement, but not as good as if we segment and base our calculations off of the center of mass. So here we ended up with an inter-class correlation of 0.96. So we know that this method is a little more tolerant to small errors. If we consider then taking automatically segmented discs using a neural network, hopefully all of that variance kind of disappears. We also looked at how to calculate lumbar lordosis. And again, we kind of threw out the idea of utilizing end plates. Instead, we are utilizing the orientation vectors for the top and bottom disc and calculating the lumbar lordosis based off of those vectors. Unfortunately, I think our lab kind of trained each other a little too well. So they already had a very good agreement with an interclass correlation of 0.98, but it did improve with the semi-automated method as well. Next, we thought we would tackle the good old Furman grade. As we kind of all know, the Furman grade is pretty subjective. Different graders might grade these slightly differently, especially when you consider things like herniated discs. You might get some variance there. And also, there's not a good sort of, it's, a ranked parameter and not as quantitative as we could make it. So we are trying to utilize several different imaging modalities in order to kind of tackle how degenerated a disc is on an MRI image. So one thing we've done is we've looked at diffusion-weighted imaging. Diffusion-weighted imaging is designed to detect random movement of water protons. And the B value of the image indicates a relative weight given to diffusion. When we take a DWI at several different B values, we can then construct an apparent diffusion coefficient map, which can be very useful for several different reasons. And we'll discuss those reasons here today. So for this study, we perform this at Irkutsk Scientific Center of Surgery and Traumatology. So that is a center in Siberia. They had a 1.5 Tesla MRI scanner that they had only gotten about 3 or 4 years before we started the study. We performed T1 weighted, T2 weighted, and ADC mapping of 47 patients. And the DWI was converted to ADC with this mapping system that we showed on the last slide, where we have different B values and intensities for the DWI images. And this is what an ADC map ends up looking like. Here, if you're utilizing a spine or abdominal coil, you'll get this sort of wraparound effect outside of the coil center. When we looked at the ADC value changes with respect to Furman grade, we see that we do have a nice sort of step down of our ADC values for each degeneration grade. But one thing we also noticed about these images were that they really helped us to define where the nucleus pulposus was. So here we can see a protrusion type disc, and we can see if we overlay this apparent diffusion coefficient map onto a T2 weighted image, we get a nice picture of where that nucleus pulposus is. Here we show it in an extrusion type herniation and in a sequestered type herniation. So we were interested in kind of exploring that a little bit more and asking the question of, are ADC maps a little more accurate at determining where the nucleus pulposus is versus T2 weighted images? So we started off with good old segmentation again, and used segmentation of the T2 weighted images to define where the boundaries of the discs were for the ADC maps. So that's what you see here is ADC map masked with the segmented discs. In regions where we had too much artifact, we did cut them down to just be the accurate discs. So from there, we looked at the histograms of these different images for each patient. So what we did was we plotted the histogram of the image. So for this image, we see 2 peaks, and we performed peak fitting on these. And we used the fitted peaks to determine where the nucleus pulposus and the annulus fibrosus were. So actually, we did the peak fitting on the T2 weighted images, and then utilized those to calculate things. Well, actually, no, sorry. We did the peak fitting for both the ADC maps and the T2 weighted images, and used our means and our standard deviations to define our regions that we considered nucleus pulposus and our regions that we considered annulus fibrosis. So when we look at the NP area based off of this histographic definition, we see that for different Furman grades, we see a reduction of the NP area in both the T2 weighted image and the ADC image. But notably, the ADC line is above the T2 weighted image line, meaning that the ADC image is picking up a larger volume of NP. And we see that in each lumbar level that we looked at. So the next steps for this process are to investigate which is more accurate. So what we've done is we've taken cow tails and performed some MRI on them, and we're doing histology, and those results are still to be determined. Next, let's talk a little bit about biological therapies for IVD degeneration. So how does this kind of fit into the predictive modeling of intelligence-based spine care? I think there's a multitude of ways that we can utilize computational technology to bolster the success of biological therapies. First, let's consider stem cell therapies. The idea that we can regenerate the intervertebral disc is very, very compelling. And there are quite a few clinicians, scientists, and engineers devoted to the study of this concept. There are many promising stem cell therapy strategies in development, but so far we have seen clinical studies having cell doses ranging from 1 to 100 million cells. So is there a target dose that we should aim for after a clear dosing study? I don't believe so. I believe this is going to be patient specific. And I'll kind of outline our method for figuring out how cell dose should be calculated. So the primary reason for there not being probably a single cell dose that's right for everyone is because of the disc microenvironment. The disc is the largest avascular structure in the human body, and as discs age, a combination of different degenerative changes cause even further reduction of the ability of glucose and oxygen to transport through the disc. So stem cell therapies for the disc will inevitably add more hungry mouths to an already starving population. So assessment of the nutrient capacity of a person's disc might be the key to proper patient selection and dose determination, and ultimately the success of those therapies. To assess nutrient capacity, my lab built patient-specific mathematical models of glucose, oxygen, and pH based on disc structure and diffusion coefficients pulled from MRI images. We were interested to see if we could infer nutritional capacity by Furman grade, or if we needed to assess a larger array of patient-specific factors. To build these models, my graduate student Sonia Ahrens and postdoc Ludmila Bardanova used a combination of machine learning and finite element modeling. We used regression-based peak fitting of MRI image histograms, as we saw in the last portion. And in order to segment the different regions of the disc, we utilized that method. We also used interpolation-based affine registration and image filtering to put different components from 3 types of images, T1 weighted, T2 weighted, and DWI images together. From these inputs, we were able to take the apparent diffusion coefficients from the nucleus pulposus only, because the signal's not strong enough in the annulus fibrosis, and plug those into a COMSOL model. We also took the structures from the T2 weighted images to define where our end plates, our annulus fibrosis, and our nucleus pulposus should be. After we did this, and my student Ward Shalash did these, we found kind of these beautiful maps. I want to point out several things. One, we do see the same sort of dead zones that other people have seen in their studies. And that is kind of at the interface of the nucleus pulposus and the annulus fibrosis. We see with degeneration, most of the glucose gets reduced. We see oxygen also getting reduced until grade 5. And then we see similar for the pH. When we simulate an injection of cells into a nucleus in 3 doses, similar to published doses for cell therapy, so that's 4,000 cells, 6,000 cells, and 11,000 cells per millimeter cubed, we do see this reduction in predicted glucose levels. So one thing that we were really interested in was a sensitivity analysis of where a single parameter was modified by 50% to show that disc size was one of the most important factors in determining glucose concentration. And that's disc size overall, that's not the disc height index. So this kind of throws out the idea to us that we can simply use Berman grade in calculating sort of what a cell dose should be. So really the patient anatomy and the size of their disc is pretty important in determining what the cell dose should be. Another hot topic in predictive modeling in spine care is the identification of intervertebral disc, degenerative disc disease phenotypes. So the identification of phenotypes would aid in patient selection for specific treatments, prediction of disease progression, and interventional timing. So for this study, my students, Joe Chen and Ludmila Bardanova, along with my surgical collaborator, Vadim Vivaltsev, investigated the feasibility of patient phenotyping using 21 variables collected from 95 pre-surgical patients. So because they were pre-surgical, we were able to obtain tissue samples during their surgeries as well. So we had information on pain, disability, pre-surgical MRIs, their sex, BMI, age, and tissue samples for each patient. And after many years of processing these samples and data, we are nearing submission of this work and are really excited to show you our results today. So first, we ran a principal component analysis on all of the data. This machine learning technique reduces the dimensionality of large data sets, such as ones with 21 variables. Here we had 2 principal components capturing roughly equal variability. Each of the 21 variables is kind of listed in order of importance and how powerful they are in predicting these different principal components. After we reduced the dimensionality, we ran a clustering analysis using k-means clustering. And here we found three different identifiable groups. We did this based off of the elbow method. So we did look at a lot of different ways of clustering and determined that, that our best fit was with 3 clusters. When we then step back and take a look at each of the individual metrics for these 3 different groups, we see that we have 61 patients in group 1, 11 patients in group 2, and 25 patients in group 3. We actually ended up with quite a lot of significant differences between these patient groups. So for instance, we see that group 2 is older, shorter, has worse pain and disability, has a lower weight but higher BMI. They have more collagen 1 variation. Collagen 1 variation was calculated from our immunohistochemistry that we performed, and then we did some image processing on that and histographic analysis on those in order to determine how dark our staining was, as well as how variable our staining was across the different samples or within a single sample. So that's what collagen 1 variation would be. And we also had less collagen 2. And interestingly, this group number 2 had a more normal cell distribution. So lower scores for cellularity down here indicate healthier cellularity. So they were older, but their cellularity seemed to be just as good. They fared worse during their post-surgical metrics, but their overall scores for things like the diffusion coefficient and the Furman grade were not worse than group 1. So this was kind of an interesting find here. And then group 1 and group 3 were sort of distinctive by group 3 being slightly older. They were about 43 versus group 1, which was about 40. So they were slightly older, and they did have more degenerated discs, as we see in their Furman grade and in their diffusion coefficient decrease here. So naturally, this group does perform worse following surgery as group 1. One interesting thing I would like to point out was there was no difference in their pre-surgical pain or ODI. That's the disability index. So all of these patients came in kind of looking the same from their pain and disability level. We can see before the surgery, there are some differences in degeneration amount. And then one group is kind of a conundrum where they're older, we would expect them to have worse discs, but they don't, but they do fare worse during post-surgical. And a big kind of find with that is that that group contained a lot more women, that group number 2. And group number 1, which remember group number 1, 2, and 3 all had similar pain and disability. Group number 1 was younger, but they tended to have more Schmorl's nodes. So that kind of points to me at some mechanistic differences there. So in conclusion, predictive modeling can play an important role in surgical decision-making, patient fit assessment for biological therapy, disease phenotyping, and prognosis. I have a few quick advertisements, I suppose. So one thing that our lab has done recently that Ward Shalash, my graduate student, has done has been to Cryofreeze the intervertebral disc. These were done on bovine intervertebral discs, and we're hoping to move this to human intervertebral discs shortly. This was another image processing type project for us. So what we did was we looked at the amount of DMSO, which is the cryoprotectant penetration into intervertebral discs using CT. DMSO is visible on CT, and we were able to calculate the shift in the histographic peak for the segmented intervertebral discs. And this told us basically when we had full penetration of the DMSO through the disc. And then following that, we were able to freeze the intervertebral discs, and we had near perfect cell viability following that freezing. I can't share with you the exact details of how we went about getting that DMSO into the disc, but if you are interested in or have needs for human cryofrozen intervertebral discs, we're hoping that we're able to provide those to you shortly with some collaborations with different companies. I would like to acknowledge all the people who have performed this work with me. And another bit of an ad here. I want to thank you for your attention and highlight some skilled candidates for your team. So this year we have Ward Shalash getting his PhD this spring. He's seeking a position broadly in biotech as a postdoc or in industry. He performed a lot of the work you saw today on transport phenomena, image processing, cryofreezing, and he's also done quite a bit of work with bioreactors that we're performing to validate our mathematical model on cell dose. Joe Chen is getting his master's this year, and he was the one who performed the principal component analysis project, doing patient clustering. He's skilled at machine learning, immunohistochemistry, and image processing. He's looking to be a research associate somewhere or a lab manager, so consider him for that. And Lindsay Benaj is almost a PhD as well. She's graduating the end of the summer. She's looking for a postdoc or industry position in ortho tissue engineering or rehab engineering. She works with bioreactors, metabolomics, and biomechanics. I didn't get a chance to highlight her work looking at basically the how inflammation affects intervertebral disc metabolism and metabolic pathways.
Thank you, Morgan.
Talked pretty fast, I suppose, so I got done a little bit early. I'm happy to take any questions.
Thank you for your presentation. I'll start while people are getting their thoughts together. So I have a question about the study looking at recurrent herniations, and you identified some factors that were associated with those who are higher risk versus lower risk. And I'm curious if of those factors, there are some that are modifiable, and if you've got work currently going to see if that can influence, targeting those in some fashion can influence the actual rates seen clinically.
Yes, so I think that's one of the real benefits in running this type of prediction using a like a regression model. Because we do get a sense for if you modify one of these parameters, how much does that change this reherniation risk? And BMI was an important predictor for reherniation, as well as smoking. So patients who smoked were more likely to reherniate. So those are both modifiable factors. I imagine that there's also a lot of spinal musculature at play here. We did not look at that in this study in particular, but we hope to in the future, looking at paraspinal musculature and how that affects it, because that would be another modifiable factor where you could send a patient maybe to physical therapy preoperatively and hopefully build up that musculature to try and mitigate their risk.
Great, thank you. Aaron, I see you pop up. Did you have a question?
Yeah, thanks, Morgan. That was a great talk. I had a question for you, I guess more generally about kind of getting some of these AI-based tools into the clinic, and sort of what your experience has been with that, and what are some of the challenges and opportunities, and maybe even barriers that you've kind of had to overcome to getting these tools into the clinic?
Yeah, so I think there's different philosophies by physicians on the utilization of predictive modeling. So some will tell you that their experience matters the most, that these predictive tools they prefer not to use them, and then particularly maybe the younger guys like the tech tools, and kind of want to add those to their practice. We also see that physicians at research hospitals tend to be more interested in sort of introducing these technologies. So that's kind of our target for selling our predictive modeling for the reherniation risk. So I think the challenge is really you need adoption by these research hospitals, by the people who are willing to utilize the tools, and then you're kind of in the slow process of getting everybody else on board as you have these kind of thought leaders out there giving presentations on how this has improved their practice. Another big challenge for getting this translated is who pays, right? So we have this very complicated ecosystem of payers, providers, and patients. The patients often don't know that they have options when it comes to surgery, because different physicians they have the procedures that they like to perform. That's an aspect of their training, that this is their go-to for different surgical options. So, you kind of are battling against that a little bit too. But anyway, we're kind of investigating right now a pricing model based off of reduced reherniation, so cost savings. So the hospital saves money if the reherniations are reduced within the first 3 months, and payers save money if it's after 3 months, because it's no longer considered a herniation or a complication from the original surgery. So that's kind of our next steps, is to run a trial between a payer and a provider and see, where the maximum cost savings are. Likely, what you're looking at is trying to, sell directly to the hospitals and capture cost savings there.
And Morgan, some of the things you showed with the automated segmentation and calculation of things like lordosis and Furman grade, so forth, do those measurements fit into this algorithm for reherniation risk, or are those incorporated in other diagnostic strategies?
Yeah, so those all do feed into the reherniation risk. So what we're going to need to do is kind of recalculate everything that we did at the one institute based off of our sort of more tolerant methods for DHI, lumbar lordosis, and Furman grade. And I think that will also make it much more broadly useful across different institutes. But I think each of those metrics can also feed into predictive analytics for a lot of other types of surgery, or just for patient phenotyping. So that's kind of where this is all going, is to put, these sort of improved image processing, methods in with all of the other work, I guess.
Yeah, one thing that we talk about is, and maybe struggle with to some degree, is this balance of effort and costs associated with measurements, and the benefit in terms of treatment matching or outcome prediction, et cetera. So I guess my question is, how do you decide? Is there a process that you go through to decide which measurements from imaging are the ones you're going to go after because you feel those are going to contribute most to some decision tool? Or is it that you want to generate as many variables as possible and let the analytical approach tell you which ones are most important? Is there a process that you go through?
I think I'm kind of the school of thought of, analyze as much as you can and, base your predictive analytics off of whatever shakes out as being independent predictors.
Okay, any other questions? Maybe
Although I do put a particular focus on anything that seems, biomechanically relevant.
Yeah, one last question I guess I would have is the practical aspect of getting images out of a medical system, you're doing the post-processing, calculating measurements and then getting those back in to a medical system where they can be combined with other clinical data and presented to the clinician. Is that an aspect of work that you're working on, or is that something that's kind of to be done in the future?
That's to be done in the future. We've had some conversations with Epic about, the possibility of creating an app within their system. Likely, we're going to leave that for whoever acquires us. I believe is the goal.
Okay, terrific. Well, if there's no other questions, well, thank you all for your attention, and thank you, Morgan, for spending the afternoon with us, and look forward to seeing you at ISLS in Boston.
All right, thank you. Looking forward to
Take care,
seeing you.
everybody. Thank you.
Bye.
Thanks, Morgan.
Bye.